Medical Campus, one of the physician leads for our statewide quality improvement collaborative called DEFINE, which stands for Data-Driven Engagement of Families to Improve the NICU Experience. Thank you so much for joining our quarterly webinar. Today, it's really my pleasure and honor to welcome our speaker, Dr. Christina Fisher, who will be presenting on her work related to communication in the NICU. Dr. Fisher is an assistant professor of pediatrics at the University of Colorado School of Medicine. She's also a neonatologist at the Children's Hospital Colorado and the University Hospital. She received her medical degree from the University of Michigan, and then did her pediatric residency and chief residency at the Oregon Health and Science University, and then completed her neonatology fellowship here at the University of Colorado. And she's been on faculty this year, and we've been really fortunate to have her within our group. And so this is a relatively informal group, and so if you have questions, please chat them in real time, and we'll try to get to the questions at the end of this session. I'll pass it over to you, Tina.
Great. Thank you so much for that introduction, Susan. It is really my pleasure and honor to get to chat with you all today about our shared passion of really understanding and improving communication in the NICU for our families. So, like Susan said, feel free to chat in questions or interrupt. I'm really happy to make this whatever you need. I have nothing to disclose. So here are the objectives, or really the roadmap for the next 30 to 45 minutes. I'll first review the literature surrounding the importance of communication, particularly in the NICU, and highlight how that's one important piece of family-centered care. I then will review a local project that we did that explored caregiver communication preferences in the NICU setting and the findings that surround the disparities for non-English speaking families. I wanted to start off this talk by really sharing a parent's experience, since this project really centers on that. And I was able to have a conversation with Emily over Zoom, and many of you may recognize her, and she may be on this call. But she is an incredible former NICU mom to twin boys who were born prematurely and cared for at our NICU. We were able to have a conversation about communication, and as she reflected on her boy's hospitalization, she had to share this about kind of her experience communicating with providers. And let me know if you can't hear.
I think back to our time in the NICU, overwhelmingly, we feel like there was great communication with our providers. From start to finish, we felt like we were heard, we were included in rounds, and they really made an effort to just be clear with us and to check in on us, which we really appreciated. And I think the hard thing, though, is that there were moments that stuck out to us when communication could have been better, and those moments can be really impactful when I think about our stay in the NICU. Like, my mind, is drawn to the really hard moments, and sometimes that was a result of something our kiddos were doing, and sometimes that was a result of communication or poor communication between us and the staff. And so one incident that kind of sticks out in my mind from our experience there was following one of our kiddos' second surgery. So we had twins, and our twin B kind of had a harder stay in the NICU. He had emergency surgery for a bowel perforation when he was 5 days old. And then when he was reconnected, he was intubated for that surgery, and they weren't able to extubate him right after. And then over the next few days, he had developed a blood infection, and a central line infection, and a lung infection. So it wasn't super clear, like, the order of events, but he was pretty sick. And so when we were talking with our provider, trying to understand, like, what the impact of this extra week or so that he was intubated or would have, the provider said to us, well, if he is extubated, and then finished her sentence, but I don't think that I actually heard the rest of that sentence, because the use of that word "if" kind of started sending me to a spiral of worry. And I, moments after that, I went to our nurse, who was one of our primary nurses, who we trusted, And it was probably one of the most vulnerable and humbling and helpless moments of my life, asking her, is Mason going to die? Is my kid going to die? Am I missing something? Because I'm here thinking like, it's going to take extra weeks for him to, wean. And am I just so far off in understanding the severity of the situation that like, he's not going to make it? And it was horrible. That's like one of the hardest moments and the most helpless moments that I had in the NICU. And while I think, I'm an occupational therapist and I work with patients, and I understand that there's a lot of pressure to like say the exact right words. I think that creating an environment where the person you're talking to feels comfortable to clarify in that moment, rather than worrying or going down that spiral after you walked out of the room, is so important. Because had I felt like I could say, hold on, wait a minute, you said if he's extubated, is that, what does that mean? And if they had said, oh, I mean when, like I misspoke, and I could have avoided that whole, all of the stress that I felt after that. So yeah, I think that's something that really stands out in my mind, and just remembering that even the parents with smiles on their faces at the end of the day are having a really hard time. This is likely the hardest thing they've ever experienced in their life and ever will experience in their life. And with that, I never expected our providers to be perfect communicators, but just again, like creating that space where I can clarify, or I can where we can keep that channel of communication open, I felt was so important. I think.
Great. So Emily's testimonial really highlights the importance of communication, and I think she touched on some other things that really encompass family-centered care. And family-centered care, according to the Family-Centered Care Task Force, is defined as an approach to the planning, delivery, and evaluation of healthcare that's grounded in a mutually beneficial partnership among healthcare professionals, patients, and their families. And there's a large body of literature on the importance of family-centered care, particularly in the NICU. This likely comes as no surprise to all of us since we have an interest in family engagement. But to quickly review, here is the proposed 5 pillars of family-centered care. And one of these pillars is information sharing. And when you think about it, there is a significant amount of information that is exchanged every single day in the NICU between providers and nurses, providers and caregivers, one caregiver to another. And we could keep giving examples. And so communication is a really important part of family-centered care. And understanding the caregiver's experience with provider communication is an area of interest of mine, which prompted the study that I'll be reviewing later that we completed here. So why does this matter? Ensuring that parents are communicated with effectively is vital to family-centered care, as it allows caregivers to have a true understanding on the clinical status and plan of care of their infant. And this fosters caregiver engagement. And we know from a host of literature that increased family engagement leads to improved outcomes. This is supported by a randomized control trial by O'Brien et al. That was published in The Lancet about 5 years ago that really looked at randomizing family integrated care to standard care. And family integrated care was care where the families were frequently at bedside, encouraged to participate in their cares, do things that typically a bedside nurse may do as far as hanging the tube feeds up. And this study showed that infants who were randomized to the family integrated care arm had improved weight gain, increased high frequency breastfeeding at time of discharge, and decreased parental stress. Another integrative review showed that increased engagement has a positive impact on both parent and infant outcomes. So infants had improved oxygen stabilization, motor development, improved cognitive and language development. And there was also an impact on maternal mental health, well-being, and a positive impact on maternal-child bonding. So this really is important. Going back to the video statement from Emily, parents likely don't expect providers to be, quote, perfect with their word choice or communication style, but this did make me wonder, has this been studied before? What has been identified in the literature as weaknesses between staff and parents when they're communicating? And this is a study of almost 10 years old that came out of Sweden that surveyed over 250 parents admitted to a level 3 NICU to really assess the parent perception of strengths and weaknesses of communication from doctors and nurses caring for their baby. 206 participants answered questions relating to the weaknesses that were reported from communications from doctors and providers. And this slide here shows table 4 with the main weaknesses that were identified. So about a third of parents reported a lack of emotional support, with didn't take time being the highest reported subcategory within that. Almost half of parents identified information giving as a weakness, with poor information, unclear information, using difficult language, or having information that was given via nurses as reported subcategories. And then also 35% reported organizational problems and their desire really for easier access to the conversations with their baby's providers. Many expressed a desire to be present during the doctor's rounds on their infant, and also there were different attitudes about different providers, the lack of continuity, and then also the lack of collaboration with the obstetric ward. Parents did have an option to leave an open-ended comment following their response on the survey, and some quotes that I wanted to share that really stood out to emphasize these points, I'll say here. So the first is, information should not go through several people. The doctors tell the nurses things, but it would be better if they just informed parents directly. Another parent said, it felt strange not to meet the doctors who make decisions about the treatment, but it was okay because the nurses were very good at communicating. And then one parent also said, as a parent, you want to do as much as possible and be involved. It often felt as if he belonged to someone else. In light of those weaknesses that have been identified, it'd be important to understand what studies have been done to try to define, quote, adequate communication with NICU families. And so this is a systematic review, kind of taking together a lot of literature that's been research studies that have been done looking at interpersonal neonatal parent and provider communication. And these looked at qualitative studies, and qualitative studies are those that use interviews as the primary data source. And that's a really great approach to these types of research questions, because it can really get at the lived experience of parents who share a common experience, like being in the NICU or having their child in the NICU. And so based on this synthesis of all the data of the qualitative research that existed, these authors postulated a new framework for adequate communication that encompasses 4 main functions. And this figure here shows the 4 main functions that they propose. So the first is building and maintaining relationships. The second is exchanging information effectively. The third is sharing decision-making. And the fourth is enabling self-management. And they came up with this catchy acronym to try to drive this point home, saying that adequate communication really consists of a tailored attention to the topic. So what is being communicated? Is it too much information, too little? And paying attention to the preferences of parents. The aims, why is there communication? What is the point that we're trying to get across? The location, where is it taking place? The route, so who is giving the information and who is participating in the overall information exchange. And then design, so how is the information being delivered and communicated? And so I wanted to go through these 4 main functions and give an example of what that may look like in the NICU. So the first is building and maintaining relationships, and they describe that as the use of inclusive, supportive, considerate language, and really responding to the parents' emotions. And so an example of this could be really getting to know the family, getting to know them beyond the baby that's at their bedside, and using their first name in conversations. Something that we may think of as typical relationship building, but it seems like this can really go far when we're communicating with our families. The second is thinking about how we exchange our information. So providing clear and timely information, giving the parents the opportunity to share what they know about what you are discussing. And an example of this could be trying to really use patient-friendly language when explaining things to our caregivers. And then, of course, giving the caregiver the opportunity to ask questions and share back what they understand from what you just told them. The third function was sharing decision-making, so allowing parents to take their preferred decision-making role and offering them the tools that they may need to participate meaningfully. And an example of this, a baby that I was caring for last year was getting really close to showing feeding cues, and an example where we really allowed the parent to weigh in is discussing what her goals were with feeding her baby. Did she want to breastfeed her baby? Did she want to introduce bottles before trying a breastfeed? So really like understanding what is important to the families and allowing them to participate in decisions that they can. And then the last is enabling self-management. So this really gets to the empowerment of parents through positive feedback to be able to care for their baby, not only throughout the admission, but also upon discharge. And I know that a lot of this empowerment comes from the nursing staff and the therapists who are at the baby's bedside and doing a lot of the cares for the baby. But an example of this could be providing positive feedback when you do see a caregiver participating in the care of their infant, even if it's something as simple as changing their baby's diaper. While it's great to know the framework that the literature has provided for communication in the NICU, one thing that may inherently affect a provider's ability to, quote, adequately communicate with a parent is their presence at their baby's bedside. And so what does impact a parent's ability to be present at their infant's bedside? Work has been done to look at this locally. Dr. Stephanie Bork did a prospective observational cohort study of maternal infant dyads born less than 32 weeks and looked at factors that really were associated with maternal presence at bedside. She found that the presence of other children, an increased distance from the hospital, a lower socioeconomic status, were all associated with decreased presence. The other work that's been done looking into presence at bedside found the same findings as Dr. Bork, but also noted that minority race and ethnicity was also associated with decreased parental presence in both mothers and fathers. And so knowing the things that are associated with decreased parental presence is important because if we identify that a family of an infant that we're caring for has one or more of these factors, it's possible that more proactive communication via a phone call update or something else will be required on our end in light of them not being able to be at their baby's bedside 24/7. So based on the literature that we've reviewed so far, we've learned how communication is tied to family integrated care and engagement, with increased engagement leading to improved outcomes. We've learned about the various sort of weaknesses that were identified from NICU parents in Sweden and our proposed framework for adequate communication. And we've also learned what affects a parent's ability to be at bedside. However, I did want to kind of pause to share what inspired me to look into this further, to highlight what's missing in the literature. And so my first block at Children's as a fellow, I was caring for a cohort of about 8 patients. And I found that one of my patients had a parent with limited English proficiency or the inability to speak, read, and or write English well enough to be able to be understood and understand without the aid of the interpreter. And I found that I would try to update this family regularly, but they frequently were not at bedside during rounds. And I found the day got away from me oftentimes before I was able to call them with an interpreter. And when I reflected on my 1 month of service, I found that I updated them a lot less frequently than the other parents of the infants that I was caring for. And so I sadly don't think that this is an uncommon scenario. I think we all want to update our families, but challenges do exist, especially with families who have limited English proficiency. And so this made me wonder kind of these 4 things. Do parents even need or want to be updated daily from a provider? How and when do parents want to receive updates, especially if they aren't present for rounds? Beyond what leads to a parent's ability to be at bedside, what barriers exist for families to be able to receive timely and effective communication. And then lastly, and something I'm passionate about, is what disparities exist in the frequency and quality of communication, particularly for families with limited English proficiency or racial ethnic minority backgrounds. And so we completed a study to try to answer and understand these 4 questions. I did just want to highlight that we know communication disparities by primary language exist. And this figure is taken from a study by Dr. Palau, who did a study in our NICUs here in Denver, looking at the disparities in communication between English-speaking and Spanish-speaking parents in the NICU. So breaking down this figure, this looks at the number and percentage of encounters that doctors and nurses had with Spanish-speaking parents. And it breaks down how the percentage of encounters that were done in English, or the dark gray bars, or Spanish in the lighter grays, and then also the different shades of lighter gray tell if it was an in-person interpreter, in Spanish, or a phone interpreter. And what this shows is that doctors and nurses were communicating with Spanish-speaking families more frequently in English than their primary or preferred language. And this matters because the same study showed that Spanish-speaking parents were 4 times less likely to correctly identify their infant's diagnosis, or even be able to identify their infant's diagnosis, compared to English-speaking families. And so this work really kind of ties in with the work that Define Colorado is doing, since we all know that this group is aimed at increasing engagement in an equitable manner. So I just took an aim statement from the key driver diagram, and it really is focused on improving parental report of engagement and reducing disparities. And so this is the key driver diagram for this group, and this really ties in nicely to the question that we were trying to answer. And I think the overarching goal for all of us who are involved in caring for NICU babies and their family is to make timely, quality, and an effective communication in a patient's primary language the standard. And by doing this, it will in turn lead to increased caregiver engagement and satisfaction, which will hopefully lead to this continued, sustained, effective communication cycle. So to really try to understand the preferences that our NICU families had, I did a mixed method study, meaning I started with qualitative data, or really doing interviews with the families, to then drive a quantitative data, which is what we think of as classic kind of numbers data, in the context of the same project, and then looking at the results collectively. So for the qualitative portion, I did interviews with parents here in our NICU, really just wanting to hear their experience, talk with them, and learn what was and wasn't going well with communication. Based on our approach, we wanted to complete about 15 to 20 interviews. And to be eligible, a caregiver had to have a baby admitted during their primary birth hospitalization for at least 7 days and have a primary language of English or Spanish. To do the interviews, we developed an interview guide, and we did a semi-structured interview guide, meaning we had general questions and things that we wanted to probe and talk with families about, but there was some flexibility in the order that questions could be asked, and also the interviewer could probe based on just the flow of the interview. And the things we wanted to explore were what is and isn't going well with communication from a family's perspective. What information do they want to get, and from who? How frequently do parents want to be updated? We also wanted to understand what the impact of My Chart, or an app that's available through our EHR, has been on their experience in the hospital and the communication that they receive from providers. And then we also wanted to explore the impact of primary language on the receipt of information and updates. And so all English interviews were completed by myself when I was not on service nor caring for any of these babies. And the Spanish interviews were completed by 2 Spanish-speaking members of our research team. And what we did is we used this interview guide to talk with families. And all of these interviews were recorded that could then be transcribed and then coded to look for themes and analyzed in a way that we could really identify what our parents are trying to say from a communication preference perspective. And I have to say, it was really enlightening and just fun to get to spend 30 to 60 minutes talking with families to really understand their experiences with communication. This slide here gives some characteristics of the infants and their family members who participated in this study. And just wanted to highlight, we had a wide variety of gestational ages and birth weights. We had a little bit higher percentage of outborn versus inborn infants. We had an overrepresentation of the average kind of percentage of Spanish admissions to our NICU. And then the timing of the interview was about 1 month into their infant stay. The things that are not listed on this slide is the wide variety of primary diagnoses and levels of acuity that we were able to capture with this population. So we had some infants with congenital diaphragmatic hernia, some with severe HIE, requirement of ECMO. We had some late preterm babies with feeding difficulties. So we really had a wide variety of patients and families, and we were able to capture families at different time points in their stay. So the range of the length of stay at time of interviews was from about 2 weeks to almost 3 months. Once we completed these interviews and coded them and analyzed them, we really found 5 themes that emerged. So 5 themes that we just kept seeing over and over in each of the transcripts. And I will share each of those with a representative quote from the transcripts on the following slides. So the first theme and thing that we learned is that personal connection really matters. Families had a lot of lovely things to say about the communication that they were receiving, but it was clear when providers and staff took the time to get to know families on a human-to-human level, it made that information exchange all the more effective and it improved communication. So this mom here reflected on the time where she felt she was communicated with the best, and she said that the provider was empathetic. It wasn't like, he's fine, we'll go over this, but it was human to human rather than this is my job and then I'm leaving. Another parent reported that it's always better when you have that connection and rapport with the provider, because there's inherent trust in what is being said. So she reflected that there was one provider who took the time to get to know them. They understood each other's communication styles, and she trusted what that provider was telling her because they had that connection. So that's the first theme that we learned. The second thing, so part of the study, we really wanted to understand what information our caregivers prefer to hear from the bedside nurses versus what would they prefer to hear from the providers. And while some information was really helpful for families to get from nurses, examples including how feedings are going, quote, how the night was, if any events happened. In almost every interview, parents expressed wanting to hear about changes or updates to the medical plan to come from the providers and not secondhand through a nurse. And this point is driven home from this quote from a mom who said she really appreciated receiving information from someone who can give all the details about it. We also learned that families are really using technology that's available through our EHR to supplement or augment the communication that they're receiving in person. And so what's available at our institution through Epic is an app that the families can enroll in, and it allows them to see lab and imaging results, read the daily provider notes, see names and pictures of the provider care team, and a lot of other information kind of right at their fingertips. And the majority of parents really liked this feature. They liked being able to put names to faces by seeing their providers and bedside nurses' name and picture every day. And several parents commented that they read every progress note that was written. A lot of families commented that they felt this information furthered their understanding on their infant's condition without having much disconnect, and they really appreciated having something that they could reference really at any time. And so these are quotes from families that really talked about how helpful this resource was and how much they loved it. And while that theme did emerge, it seemed like there was a slightly different use for our English-speaking families compared to our Spanish-speaking families, which I'll get to in just a little bit. This quote kind of drives home another potential benefit of having these resources is if a family member or caregiver is not able to be at their baby's bedside, it's a way for them to feel still involved in quote, in the loop if they're not able to be physically there, which we know that families have other priorities and things that they have to attend to. And so having this resource that they can reference was helpful. As I was talking about, our Spanish-speaking families did seem to use this resource, but not as vigorously as our English-speaking families. And we learned that while some of the headings were in their primary language of Spanish, all of the radiology reports and daily progress notes were still in English. So if they wanted to get it in their preferred language, they had to take the extra step of copying it, pasting it into a translator. And one mom still found that that would be helpful for her, but a couple other Spanish-speaking family members reported that they just wouldn't use this feature because it wasn't in their primary language. So this really seems like an opportunity to make this more user-friendly for those who have a preferred language other than English, since it did seem so helpful and loved by our English-speaking families. Kind of along those lines, we found that our Spanish-speaking participants reported receiving updates in English despite it not being their primary language. And so one mom said, I asked them to use an interpreter, and sometimes they say just one moment, but then they don't come back with one. And this really highlights a disparity in their experience. If you're not receiving updates in your primary language, how can we expect you to have the same level of understanding and engagement as those who are? And so this really was eye-opening that this continues to be an issue, at least in our unit. Another parent reported that some just don't want to put on the interpreter. And so she found that the language was the most difficult thing, that language barrier, more than anything else in her baby's hospitalization. And then the last thing we learned from these interviews is that caregivers really did value that daily update. The how didn't matter. And so whether it's in the form of an in-person conversation, a phone call, one parent even suggested utilizing my chart. Most families, it didn't matter to them, but they did appreciate getting that daily contact and touch from a provider. And I know this text has the slide has a lot of text on it, but this point was really driven home for a mom who her baby started his hospitalization at a different NICU and then was transferred to ours. And he needed to be transferred to our NICU because he was sicker and needing some subspecialty care. And she reflected that when he was at the previous NICU, she got a phone call every single day from the provider. While at the time she thought it may be excessive, when she then came into our unit and noticed she wasn't getting that daily contact, it really highlighted that was something that she needed. Another mom kind of shared that it wasn't until she really was blunt that she needed to be communicated with every day that it happened. And she shared, it shouldn't have to take that. I shouldn't have to be so blunt and track people down and tell them. And so that made us wonder, how frequently are caregivers getting updates? It's clear that families wanted that daily contact, but it wasn't clear to us how often that was occurring. And so fortunately, we have a feature in our electronic health record that allows providers to quickly document the communication that they have with families. And so using that feature, we were able to understand how frequently we're documenting our communication and track it over time. And so these next slides are busy, but basically this looks at the percentage of days per week that had a documented communication. And so 4 out of 7 days per week would be around 57%. When we first started this work, we found that only 6% of hospital days per week had a documented communication, which likely is an underrepresentation of how frequently communication was happening, but this is the only way that we have to track it. So we did 3 interventions to really try to increase the utilization of this feature, and we found that we are now closer to about 30% of hospital days per week have a documented communication. When looking at this for Spanish, our baseline mean started lower, which is not surprising. It started at 3.6%, and through those same kind of interventions focused at educating our providers, we were able to increase it. But you can see in general, it's not as consistent of a change, and it's still lower than our English-speaking families. And so looking at the difference between the frequency of updates between our English and Spanish-speaking caregivers, we have seen a decrease in the disparity or difference between the frequency of updates from 2.5 to 1.1%. But this number is not zero, and so more work is needed to be done to really eliminate this disparity completely. I also wanted to share some of the findings from our interviews surrounding rounds, because it was really interesting to learn from families what rounds meant to them. And there really were two sides to the coin. Some families really enjoyed being a part of rounds and participating in rounds. And that's kind of reflected here on this side of the screen. Parents highlighted that that's sometimes the only chance you get to talk to the team. And so it really was a priority to be there for rounds. And one parent even said, when I miss rounds, it's hit or miss on whether I will talk to a provider that day. So for some families, rounds is the priority to participate in. On the other side of that, some families found rounds to be incredibly overwhelming. One mom said it's hard to communicate during rounds, and she said it's often because there's so many people, which is similar to what another mom said, that the communication is really more helpful before rounds. And she said they ask you in rounds if you have any questions, but it's like 10 people staring at you. And you're like, I have a dumb question and I don't want to ask in front of all people. So it's better when it's one-on-one. So I think this highlights that while we have these themes that came out of these interviews, it's really important to understand that individual's family's preference, because it may be different in one patient's room to the next. And then I hope this little sound blurb will work, but mom shared a really enlightening and somewhat entertaining story about her priority to get to rounds and how problematic and hard it can be with the variable rounding start times. Let's see.
Like, you don't know what time they'll be at your room because so every day it kind of starts at a different time, and they start and they round, but they do like 14 laps because they go like in order of how many people need to be there.
Yeah.
And so we were always like one of the first ones when he was on had a surgery because the surgeons need to leave. And then it changed and we were kind of later. And then when the doctors changed, some of the doctors just restart rounds later, I guess. So it's always hit or miss. Now it's more like looking for them and like being aware.
Yeah.
And like one morning I was like rushing in to get here for rounds and it's like traffic, and then I didn't stop completely at the stop sign, so I got pulled over by the UC cop.
So sorry.
It's okay. She gave me a warning. And it's just like stressful when you don't know what time to be here.
So that mom raised a really good point of how variable rounding start times can make it difficult for parents, especially if they're in the camp that they really prioritize rounds and want to participate in them.
Like you don't.
Oops, sorry. So thank you for listening to this journey of the research project. And I just wanted to summarize the findings of our qualitative study. So we found that caregivers really value that personal connection when it comes to communication, and that when that happens, it makes communication all that more effective. We learned that when a change occurs, caregivers would prefer to hear that from a provider rather than the nurse. And the reason for that is if they have any follow-up questions, the provider is able to answer some of those why questions that's just beyond the scope of the bedside nurse. We did learn that our caregivers are using technology, and many seemed to like it and not find that a disconnect existed between what they were reading on the app and what was being communicated to them in person. And then we learned that caregivers do value that daily contact from a provider, even when their infants are kind of convalescing or in the quote feeder and grower stage. And then we've also found that we can use our EHR to better track and hold ourselves accountable of how frequently we're talking with our families. And we found that through this work, we've even been able to reduce the difference between English and Spanish speaking families and the frequency of updates. And so I appreciate your attention, and I would love to hear if anyone else has thoughts about what they feel communication should look like in the NICU, an example of what they've seen go well or not well. But before we dive into that, I just wanted to thank the NICU families who participated in our study, Emily for sharing her experience and allowing me to share it with you all today, and then the incredible research team and this Define Colorado group that's doing such great work. So thank you.
Thank you so much, Tina, for really that engaging and enlightening presentation. Let's open it up for questions and comments. Feel free to unmute your mics or chat in. While folks are thinking about that, I'll get us started. I know this has been brought up before. You know, many providers are worried about this instant access that families have to electronic medical records. And it's interesting that in your study, you found that families were using technology and it generally seemed to be sort of a positive feeling towards it. Just curious to know if you've run into instances where excessive use of technology has led to some issues, amongst providers and families and the communication.
Yeah, thank you for that question. That certainly has come up where I'm on service right now, and it actually happened today, so I'll share this example. I think the transparency of information is really important, and while the families in our study did not find a disconnect, I think it's sometimes hard when families are seeing results that they weren't perhaps expecting and didn't have the expectation set that that result was going to come back. So a baby was supposed to have their late head ultrasound last week, but for whatever reason did not get it until last night. And the read was read overnight of having some changes concerning for risks down the road for this baby. And so the mom read it in the middle of the night. So again, had access to this information, whereas she maybe wouldn't have before. And it really caused her a lot of stress because she didn't know that the read was going to come back tonight, didn't know what we were looking for, and then it was read as abnormal. And so that was really kind of stressful for her, and it fell on the shoulders of the night team to try to address her concerns. So I think it's kind of it's a blessing and a curse having all of this information at their fingertips, because when there is something unexpected that comes up, it can be hard for families to see and read those things without having any sort of context. Where I think we've made a lot of improvement with the sharing of information is if we know that a head ultrasound or an MRI is going to be done, prepping the family, saying this report is going to come up on Epic. I encourage you not to read it. Please know we will talk about it with the neurology team tomorrow. So I feel like some of that expectation setting helps mitigate these, but certainly these situations do occur. And I think with this being such a new thing, more research should be done to look into how we can best use the technology.
It looks like we have some questions. There's a question from Pia Long who asks, are you using doulas to support NICU parents? And somewhat related, question from Erin Flanagan, similarly wondering from an interdisciplinary perspective how behavioral health providers are being used in the NICU, and if your particular study is looking at contacts just from the medical providers or other members of the interdisciplinary team.
Yeah, thank you for those questions. We currently do not use doulas to support NICU families in our unit, but I know that is something that's successfully being done in other units and has been really shown to support families. So I'm curious to hear if anyone on this call is using doulas and what their experience has been, because it seems like a really great support option for our families, but not something that we're using. And then the interdisciplinary perspective on behavioral health providers. Yeah, that's a great question, Erin. That wasn't something that we directly addressed in our study, but I think is an emerging area of interest for a lot of people looking at how we can use psychologists and psychiatrists to support our NICU parents and really bring the care they need to the unit and not have them have to leave their baby's bedside to receive.
Here, Tanisha Stamps writes, I saw you noted 30% of parents thought staff lacked emotional support. This must have been one of the studies that you provided in the background. From a provider perspective, is this due to a lack of time or inability to distinguish the quote unquote hard NICU experience versus something larger, such as a perinatal mood disorder?
That's a great question, Tanisha. And that study didn't really tease out or get beyond some of these great questions of, is it a perinatal mood disorder or something that warrants further support for the family? But I know the study did say that lack of time was a big barrier to the emotional support that these families felt that they received. So it seems like lack of time was reported in the study, but they didn't go really beyond that.
Erin highlights that it was excellent to see you highlight the disparities for Spanish-speaking families. Thank you for your research and the previous CU research you shared on communication and language disparities. Mauricio shares, at Denver Health, we had a NICU dedicated psychologist for 1 to 2 years, but unfortunately, the grant funding expired recently and no longer have the service. And so it speaks to sort of the piecemeal approach that still exists around parent mental health support during a prolonged NICU hospitalization. I think here at the University Hospital, there is a program in place. At Children's, they do have a new psychiatrist, but again, every unit different, and the magnitude of the resources, I'm sure, is variable. Janet Long comments, social work chaplains, volunteers also provide support. Does that figure into your study?
You're absolutely right. Those are such important pieces of the care team who provide so much support to our families. We were really focusing on how to identify the needs for providers communicating with families and what families needed from providers. So that wasn't a part of our study, but I think would be a potential really exciting next step to include how we can have all care team members of caring for a baby and what parents perceive their role and support to be.
And a book recommendation from Pia Long, Reproductive Injustice, Racism, Pregnancy, and Premature Birth by Dana Ain Davis. Thank you for sharing that.
Thank you. I look forward to reading that.
Indeed. Other questions, comments? All right. Well, thank you so much, Tina, for your time and expertise. And for those on the call who are not familiar with the Define Collaborative, please reach out to me, Rebecca Guili, or Brace Gibson, from whom you received this meeting invitation. I'm happy to share details about Define, as well as opportunities for you to all engage further in the efforts around supporting families during the NICU hospitalization. All right. Thank you so much, and have a great afternoon, everyone.